and we'll get started at 12.
Okay. First of all, I want to help you to distinguish seizure types after stroke and their different treatment implications. Second, I want to help you describe risk factors of seizure recurrence after stroke. And lastly, I want to recognize the challenges in treating individuals with stroke and epilepsy. So let's get started. The topic today is stroke and epilepsy. So two very, very common neurological disorders. And looking at the epidemiology of stroke, we see that it's a very impactful neurological condition. It's the third leading cause of death and disability in the world, and the second leading cause of death in the world. So number one, neonatal disorders, particularly in low middle income countries, and then ischemic heart disease, stroke. It's a very, very impactful condition. Now, looking at disease burden of neurological disorders, stroke is the number one leading cause of disease burden of neurological disorders. What about epilepsy? Epilepsy is displayed here in green. It's number 5. So we have stroke, the migraine, meningitis, Alzheimer's disease, and other dementias. And then comes epilepsy. Now, but the impact of epilepsy is very high, particularly in children and young adults. And also for these statistics, only people with primary epilepsy were counted. So in other words, people with secondary epilepsy, like epilepsy following stroke or epilepsy following meningitis or seizures in dementia or other disorders, brain tumor-related epilepsy, were not counted for these statistics. So I assume that the burden of epilepsy overall is maybe even higher than this. You all probably know these slides. This shows the incidence of epilepsy over the lifespan, and the incidence is quite high in early childhood, and then sort of it plateaus in adulthood, and then it starts rising again around at the age of 55 or 60. So why is there this rise? And that makes a lot of sense because the brain gets older, so it starts accumulating injuries. And epilepsy in many cases is a secondary reaction to some sort of brain lesions or injuries. So in these cases, you would expect these individuals to have a higher risk of cerebrovascular disorders, of bleedings, of tumors, and also of neurodegenerative conditions. Now, looking at the causes of epilepsy, obviously in childhood and young adulthood, many epilepsies are genetic, but the proportion of cerebrovascular disorders causing epilepsy rises over the age span. So in individuals with epilepsy older than 65, the majority of them will have epilepsy due to cerebrovascular disorders. And this shows you the impact of stroke that it has on epilepsy overall. And so to make this a bit more interactive, let's meet a case. Let's meet Rosa. So Rosa is a 78-year-old lady, and she was admitted to our hospital with acute onset weakness of her left arm and face and dysarthria. Initially, she had an NIH stroke scale of 6 points according to these symptoms, and the initial CT scan showed right MCA branch occlusion. So she received thrombolysis and thrombectomy. And then on day 2 after stroke, an MRI was performed, and this confirmed the right MCA territory infarction in Rosa. So far, so good. Right, now what happened on day 2? On day 2, she had 2 episodes of propagating pins and needles, and the duration was around 1 to 2 minutes each. And they started in her left hand, and then they continued propagating over the arm into her face. And they were accompanied by a couple of clonic movements of her left arm, but she was fully conscious during these episodes. So 2 episodes, propagating pins and needles, fully conscious, duration 1 to 2 minutes. And that was day 2 after stroke. So now I have a question for you, and let's try whether this works. So please take out your smartphones or other devices and join me at menti.com. So please open your web browsers and go to menti.com and use the code 76005553. And my question is, well, is this epilepsy what I described so far? So once again, please go to menti.com on your devices and use the code 76005553. Great, and we have 2 votes. It's undecided now, it's 50-50. Let's see what others say. And in this case, blue means yes, this is epilepsy, and pink means no, it's not epilepsy. It's quite undecided now, but more people thinking that this may be epilepsy after all. So let's give you a couple more seconds to decide. All right, but this may have not been such an obvious question. Right, so I would say probably epilepsy wins. So around 2/3 of you think that this is epilepsy, this qualifies as epilepsy, and 1/3 thinks this is not epilepsy. Right, let's go back to the presentation. So the answer for this is quite obvious. It's not epilepsy. It's an acute symptomatic seizure. It was a bit of a trick question because yes, it is a seizure, but it does not qualify as epilepsy. So the symptoms are consistent with a Jacksonian march. So they start in the left hand and they spread across the homunculus into her face. And this could be classified as a focal aware, sensory, or motor seizure. Or actually, she had 2 seizures. But this is a provoked seizure due to acute stroke because this occurred on day 2 after stroke. And after stroke, you have a lot of release of neurotransmitters, you have a lot of cell damage, you have some blood-brain barrier disruption, inflammation, etc. So these are all things that may be causing acute symptomatic seizures or provoked seizures. And this is quite different to epileptogenesis because epileptogenesis is the process of developing epilepsy, which then leads to unprovoked or spontaneous seizures. And seizures that occur less than 7 days after ischemic stroke are currently defined as acute symptomatic. So what would you do with this case? Should we start anti-seizure medications or not? So let's go to the next slide here. I have the next question. Please take out your devices again. Should this be treated or not? It's another interesting question, and the answers may not be quite clear. Should we start anti-seizure medications or not start anti-seizure medications? Great, good to see that so many people are participating. And a clear majority is saying they would start anti-seizure medications. Excellent, good. Right, let's go back to the presentation then. So let's go back to this concept of acute symptomatic seizures versus epilepsy. So acute symptomatic seizures are super frequent. When we look at some statistics, they even say that acute symptomatic seizures constitute 55% of all observed seizures. So they may be even more frequent than actually seizures observed in epilepsy overall. And epilepsy in general is a chronic disease that is associated with unprovoked or spontaneous seizures. And the causes are old lesions, not fresh lesions, but lesions that are old that cause epileptogenesis that is then triggering these unprovoked seizures. And usually epilepsy requires some treatment, usually long-term treatment is frequently required in these conditions. Whereas in acute symptomatic seizures, this is frequently a temporary issue. So these are provoked seizures that are caused by an acute brain insult or a metabolic problem, or even an inflammation or infectious problem. And the guidelines say that usually you do not need to treat this or only short-term treatment is necessary. But there is a big difference between guidelines and reality. So in reality, as we saw now, most people will be treating acute symptomatic seizures. Now, if you decide to treat epilepsy, probably you want to start low and go slow and then reach somehow a dose that you're happy with and then keep it as a maintenance dose in people with epilepsy. Whereas in acute symptomatic seizures, the treatment algorithm, if you decide to treat, is quite different. Usually you want to treat aggressively at the beginning because that's when the symptoms or the trigger is the strongest, right? So you want to start aggressively at the beginning, but frequently you can withdraw treatment quite quickly after the acute phase. So why is there this difference between acute symptomatic seizures and epilepsy? And one of the best epidemiological data supporting this is from 2009. And here in red, you see acute symptomatic seizures, and in green are first unprovoked seizures after stroke, TBR, I think brain tumors. And this is the frequency of having another subsequent unprovoked seizure. And you see that if you had an unprovoked seizure after stroke, the risk of having further seizures is quite high. It's above 60%. So this, with the current definition of epilepsy, qualifies as epilepsy, even if you had just one unprovoked seizure after stroke. And this is a remote seizure, so it's more than 7 days after stroke. Whereas if you look at acute symptomatic seizures, their risks are much, much lower. They're around maybe 20% according to this study. So the guidelines usually say, well, do not treat acute symptomatic seizures, but the reality is that almost always gets treated, and many patients get treated for several months or some even for years. And I like to advocate for distinguishing between sort of subtypes of acute symptomatic seizures, and I like to speak about the good, the bad, and the ugly. So what are the good acute symptomatic seizures? These are usually short and non-disabling seizures, frequently non-convulsive or very short seizures that do not cause convulsions. And these are typically single seizures, only few repeated seizures, and they occur in the first few days after stroke. And these have a very good prognosis, and usually no treatment is required for these cases. But then we have the bad seizures. So these are disabling seizures like convulsive seizures, which are associated with the risk of injuries. But seizures may also have an impact on cerebral perfusion and metabolism, particularly if you have a large vessel occlusion, if you have vasospasms like in subrecurrent hemorrhage, or if you have brain edema after, for example, after bleeding or in tumor, or if you had a recent surgery or trauma. So these are all situations where you'll be more likely to treat cases to prevent people having more seizures and having a worsening due to these conditions. And so I would suggest to treat these cases. Usually it requires short-term treatment, and the duration, the guidelines usually say it should be around 7 to 14 days, but reality is most cases, at least in Europe, get treated for around 3 months, and then they have another clinic, and then treatment is withdrawn. And even in seizures or periodic discharges occurring at the intensive care unit, we have good evidence that these have an impact on metabolism and in this case on partial pressure of oxygen. And it's related to the frequency of these discharges. So at around 2 hertz and probably even more significantly in seizures or in discharges with a frequency of 2.5 hertz or more, you start seeing significant declines in partial pressure of oxygen and also declines in metabolism. And that's also the reason why discharges with a frequency of about 2.5 hertz are defined as epileptic seizures, because they have an impact on brain metabolism. And what's the ugly? So the ugly is status epilepticus. This will always require treatment, and it has a high risk of poor prognosis in epilepsy. So this is data from the SELECT study, and this is published by our group. And here I'll walk you through this. So the first, on the left, you see data on mortality. On the right, you see data on post-stroke epilepsy. And here at the bottom, these are stroke cases or stroke survivors or people with stroke who did not have any acute symptomatic seizures. So they have the lowest risk of mortality. Here, this bunch here are all cases who had acute symptomatic seizures, but the highest risk of mortality, and it's really, really high, it's up to 80% in the next 10 years after stroke, is in those cases that had acute symptomatic status epilepticus. So acute symptomatic status epilepticus is a severe indicator of very bad prognosis. Now, what about the risk of epilepsy? It's a very similar picture. So here, those without acute symptomatic seizures had the lowest risk of post-stroke epilepsy. Those with acute symptomatic seizures, regardless of type, have a slightly higher risk. But it's definitely significantly elevated. So it's the risk is between 20 to 40%. And the highest risk, again, here you see in orange, are those with tonic-clonic seizures, with focal to bilateral tonic-clonic seizures. But the highest risk, again, is in those with acute symptomatic status epilepticus. So acute symptomatic status epilepticus is an independent indicator of very poor prognosis and a very high risk of epilepsy. So even in these cases, you may even consider to treat them long-term. So what happened to Rosa? Her seizures were not treated, but they also did not recur during hospital stay. So we were quite happy about that. We detected atrial fibrillation, and she was started on anticoagulation with apixaban. And she was started on a statin, and she received some antihypertensive medication. And then she was discharged to neurorehabilitation. But before discharge, Rosa asks you, well, what is her risk of developing post-stroke epilepsy during the next 2 years? Right, so let's go back to Mentimeter. And this is the next question for you. What do you think is the risk for Rosa of developing post-stroke epilepsy during the next 2 years? And I'll recapitulate. So she had NIH stroke scale 6 points. She had some arm and face weakness, dysarthria. She received thrombolysis. She had an acute symptomatic seizure. That was, well, it was convulsive, but it was focal. What else do you need to know? She had atrial fibrillation detected. Right, so let's wait until the answers are coming in. And so most people think this may be something around 50%. Or some people think it's maybe something around 30 to 40%. All right. Good. So how could we approach this? Let's have a look at some evidence. So this is a study from the SELECT registry, which is a large multi-center international registry on post-stroke seizures. And based on this registry, we calculated the SELECT score. And the SELECT score is called SELECT because of the first letters of the variables that are in this score. So in the score, you have severity of stroke, you have etiology of stroke, particularly large artery atherosclerosis. You have early seizures. Nowadays, they are called acute symptomatic seizures. You have cortical involvement, so if the stroke involved the cortex, and you have territory of MCA involvement, so if the stroke involved the territory of the MCA. You have a couple of points here that you can sort of count. And if you do this, well, Rosa had 6 points on the NIH stroke scale. She did not have large artery atherosclerosis. She had an early seizure. The cortex was involved and it was in the territory of the MCA. You receive 7 points, and here you can sort of read out what the risk is. To make this easier for you, we also have an app. And sort of this app can be downloaded for Apple iOS and for Android. And you can start them on your phone. So when you start it up, you see sort of, again, it's like a calculator. And you see some information about the parameters and how to use the app. You can so choose some factors and then click on calculate, and it shows you what happens. Right. Now, I was showing you a few slides back the data on post-stroke acute symptomatic status epilepticus. And because we realized that acute symptomatic status epilepticus was such an important risk factor, we implemented in this newer version of the app that I'll show you very shortly. And what else can you do with the app? You can calculate the predicted risk of having seizures in the next year. So let's imagine that, well, Rosa wants to drive the car, a stroke, recovered very nicely. And she asks you, well, when is the time that I have a low enough risk of seizures that I'll be allowed to drive the car? In Europe, our regulations say that the risk of seizures in the coming 12 months needs to be at around below 20%. So this is this red line here. And so based on the SELECT score, you can also calculate how long she needs to wait until this threshold is reached. And that's sort of an evidence-based help to our recommendations that are based sort of on some other factors. Right, and let's have a look at this. We have also a web application. Well, let me see if I can click this. There you go, super. So if you go to predictapps.github.io/select, you get our calculator, and now we can calculate the risks for Rosa. So she had 6 points on a stroke scale. She did not have any large artery atherosclerosis because she had the etiology of her stroke was atrial fibrillation. She had a short acute symptomatic seizure. The cortex was involved, and the territory of the MCA was involved. So let's click on calculate. So after 12 months after stroke, we have a 17% risk. If we increase this to 24 months, that was my question. So the calculate, which is based on data of 4,500 individuals with stroke, predicts a 25 risk of seizures. So it's quite a substantial risk, or it's not very high. So you wouldn't want to treat her as a primary prophylaxis, because epilepsy usually is defined as a risk of seizures in the next 10 years of above 60%. Now you can also look at her risk for driving. So if she waited for 3 months after stroke, which is the usual recommendation for acute symptomatic seizures in Europe at least, then she would have a 14% risk of having a seizure in the next year. So that's relatively low. She would be safe to drive in this constellation. Right, let's move on. So I was talking a lot about predicting risks, but really the holy grail of epilepsy is actually preventing the development of epilepsy and preventing epileptogenesis. And what is the current state of literature regarding epileptogenesis in post-stroke epilepsy? So I showed you that with these calculators, we can relatively easily and quite accurately predict the risks of epilepsy after stroke. Now, can we actually use that for epileptogenic treatment trials? So based on this Cochrane review, there were 2 randomized controlled trials. One was assessing sodium valproate, the other one was assessing diazepam. And overall, these two trials did not support any evidence for an anti-epileptic treatment effect of these two treatments. Now, there are two ongoing studies, one a European study, which is assessing aceclarbazepine, and an Australian study that is assessing propranolol, that have been using these models like the SELECT score to recruit an enriched population of patients, so patients that are at high risk of developing post-stroke epilepsy, and they included those, and they performed an anti-epileptic treatment trial in these cases. So the aceclarbazepine trial, the follow-up has been finalized, and the first analysis have been performed, and I saw those, and they're quite interesting, I must say. And for propranolol, I saw the interim analysis. It's also very, very exciting, but the study continues recruiting, so we'll see what the final results will be like. Now, looking at this aceclarbazepine trial, it is a phase 2 prospective multicenter randomized double-blind placebo-controlled trial. They randomized 125 cases and finalized follow-up of 18 months. And people were included who had a risk of epilepsy above 20% according to the SELECT score that I showed you, and according to the CAVE score, that's another score which can be used in intracerebral hemorrhage. And cases were randomized either to receive 800 milligrams of aceclarbazepine or placebo within 5 days after stroke. And this was given for 30 days after stroke. And then follow-up was performed after 18 months. And the question was, were cases who received 800 milligram aceclarbazepine for 30 days, were they at a lower risk of developing epilepsy at 18 months after stroke? And while the analyses are not finalized yet, but the first sort of results that are trickling in show that there may be an effect favoring aceclarbazepine. I mean, the statistics is still not finalized, but I think this is quite exciting, and we're really looking forward what this study will finally show in the end. So when you want to predict risks of post-stroke epilepsy, you will also think about neuroimaging. So neuroimaging is a very widely available method, and it's quite robust and reliable. And we also had a lot of background in neuroimaging. So let's talk you through what neuroimaging shows for predicting the risk of post-stroke epilepsy. But first, I have a question for you again. So let's go back to Mentimeter. Oops, let's make this a bit smaller. There you go. So what do you think? Does neuroimaging matter for the development of post-stroke epilepsy? Is that a relevant risk factor? And the answers are, well, no, any cortical lesion can cause epilepsy, or maybe others think that actually lesion location does matter. And again, other people might think that lesion connectivity may matter most. So let's see how people respond to the survey. Wow, this is quite one-sided so far. So most people think that actually lesion location does matter. Okay, some people think, well, it may not be such an important factor after all. Any cortical lesion can cause epilepsy. All right, but the clear majority thinks lesion location is important. All right, so how can you study this? And there's an approach called lesion symptom mapping. It's already been used by Broca, for example, to describe the area associated with motor language problems. And how you do this, you collect patients with a similar symptom, then you map their lesions on their brains, and then you map them to a common space and see where the lesions overlap. So this may be the area that's actually causing the symptoms. And lesion symptom mapping has been performed for post-stroke epilepsy, and this is one study published in 2022. And here are some clusters or blobs that you can see that were associated with developing post-stroke epilepsy. But you have to be very, very careful when interpreting these results, because the statistical thresholds used in this study were quite lenient. So it's not very robust, I would say. And again, we tried this also in our data set, and you see a couple of small clusters here and there. These were located mainly surrounding the insula and temporoparietal cortex on the right. But overall, these clusters are very, very small, and the effects were quite low. Now, we know that epilepsy is a network disease, and we know that many, many different lesions can be causing epilepsy. So there's a different approach to approach network disorders, and that's called lesion network mapping. So if you have patients having the same symptoms, but due to different lesions, this may be due to disconnection or some connectivity issues correlated with these lesions. So again, you can map these lesions, and then you can estimate the connectivity of these lesions based on a connectome that's based on usually healthy control data. And then you map the functional connectivity of these lesions. And you can do this for many, many patients or many, many lesions, and you can find some overlap, and this may be pointing to relevant areas that are disconnected or where connectivity is impaired that may be causing your symptoms. So this is called lesion network mapping. And this has also been done recently by the group of Michael Fox and Frederick Sharper in Boston and published in JAMA Neurology. And they started with a group of post-stroke epilepsy patients, but then they also validated and replicated this network in many, many different other lesions. So it seems to be a network that's not very specific to post-stroke epilepsy only, but also may predict seizures in other lesional epilepsy cases. And so this is the network that they described. And the most relevant nodes that were connected to this network were the cerebellum, substantia nigra, and basal ganglia. And you may be thinking, well, this is quite odd. I mean, these are not typical regions that would be causing epilepsy if you have a lesion to these regions. But we think that these regions may constitute an inhibitory seizure network. So this may be the smallest common denominator of lesional epilepsy. So if you have disconnection of these areas, you may have less inhibition, and the brain may be more prone to developing seizures. Very exciting data. Now, what else is there? You may have cortical superficial siderosis, and this is a study from Japan, and they also showed that if you have cortical superficial siderosis after stroke or ICH, you are more likely to develop seizures. So again, the effect of bleeding and siderosis is quite pronounced on the risk of seizures. So let's go back to our case. What happened to Rosa 1 year later? So after 1 year, she had this episode of a sudden loss of awareness with clonic movements of her left arm and face, similar to the first seizures that she had. Then she had some vocalization and grunting and tonic-clonic movements for 1 minute. So this very much sounds like a focal to bilateral tonic-clonic seizure. Then she was admitted to a hospital again. She had postictal TOTS paralysis on the left. We didn't see any provoking factors for this seizure. She had normal blood lab results, and the emergency CT head and CT angiogram showed this old lesion from her old stroke, and the CT angiogram was actually nice, so she didn't have any artery occlusions at that time. And then we performed an MRI. We saw an old stroke, and the EEG did not show any epileptiform discharges. Right. So she had this single unprovoked seizure 1 year after stroke. So do you think this is epilepsy? What do you think? All right, I don't think we need to wait much longer. This is quite obvious. So everybody thinks this is epilepsy. Super. So why is that? Because she had at least one unprovoked seizure and has a high risk of recurrence. And why do we know that she has a high risk of recurrence? She didn't have any epileptiform discharges on the EEG, but we know that probably the cause of her seizure was an epileptogenic lesion like a stroke. And in these cases, even after a single unprovoked seizure, we know that the recurrence risk is great, and we can make the diagnosis of epilepsy. Right, so now we'll want to start treatment in her. And what are the outcomes when treating people with post-stroke epilepsy? Looking at this data from Berlin, we know that ischemic stroke has usually quite a good outcome when treating these patients. So post-stroke epilepsy usually responds very well to treatment, and you have responder rates, after first treatment, above 70%. It may even be much better than other sort of lesional cases. And you also need the lowest dosages of medications. So it's quite easy to treat, to be honest. So my next question to you is, which treatment would you choose in this case? And on offer, we have carbamazepine, we have sodium valproate, lamotrigine, oxcarbazepine, levetiracetam, or lacosamide. So let's see what neurologists in Canada would do in this case. Okay, many people favoring levetiracetam so far. Some people oxcarbazepine, some would take lamotrigine. Interesting. Well, I think the situation would be quite similar, at least in Switzerland. Many people would be favoring levetiracetam. Good. Let's have a look at some evidence. So first-line treatment of people with focal epilepsy. So we establish this focal epilepsy first-line treatment. Probably one of the best evidence we have are the SANET studies. And they were published in 2007 and 2021 by Tony Mars in Lancet. And let's just look at the main endpoint, which is adherence to medication. So that's a combined endpoint. So if somebody adheres to medication, they are probably seizure-free and probably tolerate the medication well. And in 2007, the winner of the SANET study was lamotrigine, which was significantly better than carbamazepine and also as topiramate and gabapentin. Well, but at that time, we did not study levetiracetam or other medications. So there was another SANET study in 2021 where the researchers compared lamotrigine, levetiracetam, and zonisamide. And again, lamotrigine was the winner of this contest. So at least according to the SANET studies, lamotrigine should be favored in people with focal epilepsy. But we know that it's not that easy in people with epilepsy, particularly in older individuals with post-stroke epilepsy. Why is that? Because these people are usually older individuals. They may have comorbidities. They frequently take polypharmacy. They may be quite frail and vulnerable. So because of the typically higher age of these individuals, their clearance may be reduced by around 25 to up to 50%, so usually around 30% reduced clearance. So you want to start low and go slow with your medication. Otherwise, you may reach toxic doses quite quickly. And also, as we saw in post-stroke epilepsy, usually quite low doses of medication are enough. Now, looking at comorbidities, there's a high risk of osteoporosis or renal failure, depression, tremor, dementia. So these are things that you may need to consider, particularly for osteoporosis. You may want to avoid enzyme-inducing medications, depression. I don't know, I'm thinking about levetiracetam or zonisamide, sodium valproate or lamotrigine may be causing or worsening tremor, and so on. Looking at polypharmacy, there may be some interesting or important interactions. So many people with stroke will be taking anticoagulants and statins. So if you're taking warfarin, that's usually not a big problem because you can check for the effectivity or efficacy of warfarin. But if you're taking direct oral anticoagulants, that may be quite tricky because you wouldn't be regularly checking whether the medication is actually working quite fine. And the same goes for statins. So many of our anti-seizure medications, particularly those that are enzyme-inducing, may be difficult to use in people who have many medications. And again, older individuals with stroke may be quite frail and vulnerable, so they have a high risk of seizures and a high risk of adverse effects, also because of falls and injuries. Now, this is, I think, quite an interesting and thought-provoking study, looking at the effect of anti-seizure medications and direct oral anticoagulants. So at least in Switzerland, we use direct oral anticoagulants quite a lot. And we actually, well, I would say that many people do not actually consider what anti-seizure medications may do with these with DOACs, and we don't really consider whether they may be reducing the efficacy of DOACs. We know that enzyme-inducing medications may actually impact the efficacy of DOACs, which is quite severe because then the patients are at high risk of having another stroke. Also, we know that valproic acid has a high risk of impacting these medications or interacting with these medications. But I think, and this is quite interesting, that there was also a higher risk of having a stroke if people were treating with levetiracetam. And this is some real-world evidence that may be pointing to some sort of interaction between direct oral anticoagulants and levetiracetam. So I'm really looking forward to getting some more data on this. As you can see, the groups here for levetiracetam were very, very small. What else can I tell you? Now, people taking enzyme-inducing anti-seizure medications may be at higher risk of ischemic heart disease, stroke, and TIA. And this is actually a Canadian study. And here in blue, you have those taking enzyme-inducing anti-seizure medications. In orange, you have those taking non-enzyme-inducing medications, anti-seizure medications. And those here with enzyme-inducing medications have around twice the risk of having ischemic heart disease, stroke, or TI, which is quite a lot in my opinion, so you need to consider this. Now looking at post-stroke epilepsy again and mortality. Mortality in this study, this is a Swedish population-based study, was influenced by the choice of anti-seizure medication. And here lamotrigine was again the winner, and you had the highest mortality in cases who were receiving valproic acid and phenytoin. So again, these are, well, things that are quite difficult to consider in your clinic because you don't, well, you may not be seeing the effects obviously on your patients, but I think it's quite exciting to see that some medications may actually impact the risk of cerebrovascular disorders or mortality in your patients. And I would recommend that you should be thinking hard whether you want to avoid these medications or not. Right, so what happened to Rosa? 1 year later, after her seizure, she was initially started on lamotrigine, and she had some consecutive dose increases, but she had continued seizures. So then we added levetiracetam to her medication, but this had to be stopped due to adverse effects. She had some worsening of depression and anxiety. So then oxcarbazepine was added, but it had to be stopped due to low sodium levels, hyponatremia, and dizziness. And this is something that's very, very common in older individuals. So the risk of low sodium blood levels is very high, particularly following the administration of oxcarbazepine and acecarbazepine, but also carbamazepine in older individuals. So then zonisamide was added, and she had consecutive dose increases, but she still has ongoing seizures. So what would you do next in this case? And now this gets a bit tricky. What did you do? Would you add on another seizure medication? So now she has lamotrigine and zonisamide, or would you evaluate sarcogenic non-epileptic seizures, whether these are dissociative or functional seizures? Would you consider her for epilepsy surgery? Would you consider neuromodulation? Or would you add on some anti-inflammatory medication? And this is not straightforward anymore. Okay, excellent. So many people would evaluate sarcogenic non-epileptic seizures. I think that's always a good idea, particularly that because we see that many of our cases that are reported to be drug refractory actually don't have epileptic seizures, but they have sarcogenic non-epileptic effects. But overall, I would say the risk in somebody with post-stroke epilepsy or in these older individuals is not that high. But probably it would be quite a good idea to capture a couple of her seizures or typical events and see whether there are real seizures or sarcogenic non-epileptic seizures. Epilepsy surgery, well, that might be quite tricky, to be honest, because she has this pretty large stroke, so it would be difficult to figure out what to resect, actually. Add another seizure medication, yes, why not? And neuromodulation may be an interesting option, particularly in post-stroke epilepsy. And I will show you why. So this is something brand new. This has been published last year in JAMA Neurology. And this is a German study group and a German company that developed an epicranial stimulation device. It has this fancy name, EASY, and it also reflects that it's actually pretty easy to implant because it's not intracranial. So it's implanted on the scalp epicranially, under the skin. So it's very, very easy to implant. It is associated with minimal risks. And what it does, it gives some stimulation to some parts of the cortex. And this study was an uncontrolled study. So we don't have a randomized controlled trial for this device yet. And it showed quite interesting responder rates. So this is the number of 50% responders. And the responder rates were quite similar to patients receiving deep brain stimulation or RNS or VNS. So I think this is quite exciting, particularly because this stimulates brain areas that may be affected by the stroke. So frequently strokes are cortical, particularly those that are causing post-stroke epilepsy. And I think such a device or other devices may be interesting for neuromodulation in patients with stroke who have seizures originating from a certain part of the cortex. But again, we don't have any controlled data. This is uncontrolled data, and we're waiting for more information to come in the near future. Right, so let me conclude. Post-stroke epilepsy is very, very common, and it's actually the commonest cause of epilepsy in older individuals. Regarding acute symptomatic seizures, not all seizures are equal, and I would advocate to distinguish between the good, the bad, and the ugly types of seizures. We have a lot of good prognostic models for post-stroke epilepsy, like the SELECT score or the CAVE score, and you should be using those to help you judge the risk of seizures in these cases. Now, looking at stroke lesions, probably connectivity matters more than stroke location. And looking at treatment, probably you want to avoid enzyme-inducing anti-seizure medications in the elderly, and for treatment regimens, you want to start low and go slow. Thank you for your attention.
Thank you so much, Dr. Galovi, for a wonderful, very comprehensive presentation, integrating so many different aspects together, the online resources, the cases, very, very helpful. I think for all of us, both pediatric epileptologists and neurologists and adult epileptologists who care for patients who have stroke and then subsequent epilepsy. So there are a couple of questions in the chat, and I'm sure there'll be more that come in. Jacob is wondering, is there a risk of post-stroke epilepsy calculation applicable to children or adolescents that you're aware of?
No, I'm actually not aware of a risk score for children or adolescents. And the reason also is because, for this, you need quite big databases. And actually, in adults, the risk of having seizures after stroke, I haven't mentioned this, but it's not that high usually. Well, if you take all the stroke population, it's around 6%.
Yeah.
So to have an adequate number of post-stroke epilepsy cases, you need really large databases.
Mm-hmm.
And obviously, stroke in children and adolescents, it's not that common. So it would be quite difficult to do this, to get a really nice sort of data set and to develop a prognostic model.
Yeah, definitely challenging. A question about what is the difference between acute seizures and chronic seizures?
Right. So acute seizures are due to provoked factors. And chronic seizures are actually process that generates unprovoked or spontaneous seizures. So they occur in the absence of any provoking factors. And that's the tricky bit about epilepsy, because it's so unpredictable.
Mm-hmm.
And we see that not at all acute symptomatic seizures are equal. And we see acute symptomatic seizures that, for example, occur after metabolic disturbances, like in low sodium blood levels, or if somebody suddenly stopped their anti-seizure medications, or if they had withdrawal of benzodiazepines or alcohol withdrawal. Well, these seizures are very, very benign, and they have an almost 0% recurrence risk. So at least in these cases, if you want to treat them, then treat them just very, very shortly, but they definitely do not need any long-term treatment. But what we're slowly recognizing is that acute symptomatic seizures in somebody who has a brain lesion have a relatively high risk of having epilepsy later on. So it's not 0%, it's actually between 20 to 40%. In some cases, it's even much higher than that. Why is that? I think that these acute symptomatic seizures are showing you that the brain lesion actually affects the brain in a matter that can cause seizures. And it also shows you that this person has some sort of low threshold for seizures, and that they may be at high risk of having seizures later on. So acute symptomatic seizures following brain lesions are not as benign as we thought previously.
Yeah, precisely. Dr. Jones, who's also here on the panel, asking, is there a correlation between hourly or total seizure burden in post-stroke acute symptomatic status epilepticus and neurological outcome, or the development of post-stroke epilepsy? Are you aware of any work looking at that?
I'm not aware of any work looking specifically at post-stroke status epilepticus, also because it's super rare. At least when you have clinically detected post-stroke status epilepticus. The incidence that we calculated was 0.2% of all stroke cases. But now that EEG monitoring is getting more and more common, you'll be seeing many, many more of these cases having post-stroke status epilepticus or having some rhythmic discharges. Now, I don't think there's a specific study looking at post-stroke cases, but in general, we know that the seizure burden or the burden of these electrographic discharges is associated with worse outcomes regarding mortality or disability, and also worse outcomes regarding developing epilepsy later on. But this is not data that was specific for post-stroke, for people with stroke. It applies to sort of any etiologies seen at the neuro ICU.
Right. Paula Marquez, who's an adult epileptologist, is asking, any studies on status epilepticus and which medications you would use in stroke?
Well, I mean, that's really no evidence regarding this. I think there's very little evidence regarding particularly non-convulsive status epilepticus. If you have convulsive status epilepticus, obviously you have a couple of really good randomized controlled trials. So at least in Switzerland, we tend nowadays to use levetiracetam quite a lot because it's very easy to administer. It's very safe. But looking at status epilepticus trials like the ASSET trial, which was published in New England Journal of Medicine, which is on convulsive status epilepticus, the outcomes were the same when people were using sodium valproate, levetiracetam, or phosphenitoin. The take-home message is that you need to treat them early and quite aggressively. So you need to give very, very high doses of these medications in order to be able to stop status epilepticus. And when it becomes non-convulsive or super refractory, that's really an evidence-free zone. So I think you can do whatever you want to try to stop status epilepticus. And one other take-home message is that, well, if status epilepticus is acute symptomatic, then it also makes sense, just to treat somebody and don't give up very early. Because sometimes you need to treat them for 1 or 2 weeks, and then these provoking factors, they just disappear because the blood-brain barrier gets sort of closed again, and all the glutamate that's swimming around gets reuptaken. So it just needs time. And sometimes you cannot really stop status epilepticus in the first couple of days, but it just needs some time. So don't give up in the first 14 days.
Yeah, I think that's a really important message for people. What modality do you recommend in studying post-stroke connectivity? It's asked by Dr. Jones here.
What modality regarding post-stroke? So, I mean, you could, if you're using MRI, you want to look either at functional connectivity or structural connectivity. And depending if you're a French person, you want to look at structural connectivity. They have quite a lot of sort of background on that using some sort of diffusion imaging. And if you're from the US or Boston, you want to do functional connectivity, which is done using resting state fMRI.
Interesting question. Something that as a pediatric epileptologist wouldn't come across. Any concerns of higher risk of Stevens-Johnson's with lamotrigine? You spoke about the use of lamotrigine with the focal epilepsy. So are you aware of higher rates in the elderly population?
Particularly in the elderly population, I'm not aware that there would be any higher risk. And I think overall, when you start lamotrigine really, really slowly, and when you follow the recommendation to up titrate it very, very slowly, and we usually do that within around 8 weeks, then the risks of these problems are relatively low, particularly of any severe skin problems. We sometimes see some skin problems, and then we consider whether you need to stop medication or change it to a different one.
There's a question here about differentiating amyloid spells versus seizures. Sometimes scalp EEG cannot pick up interictals. I don't know if you have a comment about that.
Oh, yes, that's an excellent question. So amyloid spells are recognized more and more frequently. And but if you have amyloid angiopathy, many of these patients will have also a very high risk of epilepsy, either because of bleeding or because of the amyloid. So amyloid is very pro-epileptogenic, and also any sort of blood in the brain is very pro-epileptogenic. So I would say that common things are common. So if you have somebody with amyloid angiopathy, then think about seizures first, because that's a very high risk that this patient may have seizures. But also then you have these amyloid spells. So how would I differentiate them? In my personal opinion, amyloid spells are frequently associated with some negative symptoms. Why is that? Because the current concept of amyloid spells is that they are associated with some cortical spreading depression. So when we look at seizures, there's this connectivity. So everything happens quite quickly, usually take around 1 to 2 minutes, and are frequently associated with some positive findings. Whereas in amyloid spells, it's more similar to like a migraine aura. So the symptoms are much slower and quite frequently have negative symptoms. I think these would be helpful to really differentiate from seizures. But in the end, it's quite tricky And in the end, if you're quite unsure, you may need to do some long-term monitoring of your patients.
There's a comment from Alan Diaz asking, seems like you use connectivity tools based on the statistical analysis of neuroimaging resources. Do you use connectivity tools based on invasive EEG or raw EEG? How so, or why not?
Oh, yeah, well, I'm not an EEG person, so I read EEGs only clinically, so I'm an imaging person, so I can't tell you much about sort of intracranial EEG connectivity. But I know that the group in Boston, who's very much into this lesion network mapping, that they are using also approaches looking at some EEG connectivity, as far as I know, to look at some connectivity patterns that were associated with seizures.
Okay. Question about replacing levetiracetam with brivaracetam. Any studies that you're aware in the stroke population?
I don't think there are any really good head-to-head comparisons. So we do try brivaracetam quite a lot because we sometimes give it a chance if a person does not, well, if a person responds well to levetiracetam, but they have some side effects, and if they're not very severe, we may try brivaracetam in these cases. And my personal experience, so this is not based on any studies, my personal experience is around 50%, it works well with brivaracetam. And in the rest, well, they still have, I don't know, some affective disorders, and you may need to try another medication. But the interesting bit is that it may also work the other way around. So if you have somebody taking brivaracetam and then they have some affective side effects, you may also try levetiracetam, and it may work in these cases. So we saw it both ways, and in the end, they are quite similar, but not quite the same. So it's just worth trying, and it's really easy to swap.
Yeah, definitely. Any role, Dr. Dutta is asking, any role for the diffuse DTI in these cases that you spoke about?
Not necessarily. I think it's interesting. So in imaging, two modalities at the moment are quite interesting when it comes to seizures and status epilepticus. So the first one is DWI, so diffusion weighted imaging, where we frequently see some parietal abnormalities, and they are frequently centered on the thalamus, because this is really like a network hub that where many of the connections go through, and particularly at the pulvinar. So I believe when you have some DWI abnormalities on the MRI scan, and you see the pulvinar nucleus of the thalamus lighting up, then this is quite likely that it's ictal and not something else. And then we also know that some sort of perfusion measures are quite helpful, particularly ASL. So if you can measure perfusion on CT or MRI, then this may be helpful to differentiate, for example, status epilepticus from acute stroke. So definitely do that if you're not quite sure, if in an emergency room in a patient with epilepsy and they're having some novel symptoms, perfusion imaging may help you to differentiate this from stroke.
That's really helpful clinical pearl for people to know. So I think those are all of the questions that we have for you today. Thank you so much for joining us, Dr. Galovi, and on short notice as well, filling in. We really appreciate your time. This is a really wonderful presentation. I think we all learned a lot. And thank you on behalf of the Canadian Epilepsy Teaching Network and the Canadian League Against Epilepsy for joining us this afternoon. Thank you.
Thank you so much, and have a good day.
You too. Take care.